Hello, everyone, and welcome to our webinar. My name is Tracy Cook with Zacks Healthcare Communications. I'd like to show our audience today how you can send in your questions throughout the webinar. Our speaker will try and answer as many as possible at the end of the presentation. Please type your questions into the questions box. You can also download the handout from the handout section of the GoToWebinar control panel. I'd like to introduce our moderator today, Christine Binda. Ms. Binda is currently the Manager, Clinical Nutrition and Bariatric Surgery Program at Sharp Memorial Hospital, San Diego, California. She has received several certifications, including Certified Specialist in Oncology Nutrition and Certified Nutrition Support Clinician. She has been a co-author on several posters and abstracts on various nutrition-related topics. Welcome, Christine.
Thank you, Tracy, for that kind introduction. The title of our webinar today is Care of the Acutely Ill Bariatric Patient. Speaking on this very timely topic is my colleague and one of the experts in this area, Cheryl Holsworth. Cheryl has extensive nursing experience, including intensive care, hemodialysis, and outpatient services. Currently, she is the Senior Nutrition Specialist for Bariatric Surgery at Sharp Memorial Hospital in San Diego, California. She has a bachelor's degree in nursing, a master's degree in administration, and is a certified bariatric nurse. She has presented posters and presentations at multiple conferences and published articles to discuss the challenges of obesity in healthcare. The speaker disclosed no financial relationships associated with this presentation. This activity has been approved for 1 contact hour of continuing education. At the end of the webinar, you can obtain those continuing education credits. The URL will be provided at the conclusion of the webinar, and the accreditation statements are below. This activity is supported by an education grant from Dale Medical Products. Now I will turn the presentation over to my friend and colleague, Cheryl Holsworth.
And so with our objectives today, we're going to talk about the classifications of obesity, the impact and costs related to obesity, describe the risk and considerations in caring for the patient with obesity due to their pathophysiology, and then we'll also discuss practical approaches to caring for patients with obesity. And when we look at the classifications for BMI, it's not a perfect variable, but it is a very practical way that we can assess for obesity. It certainly doesn't account for someone who's really tall or someone who's very muscular, but it certainly is a very important guide. We also have to look at other factors such as patients' comorbidities and waist circumference, et cetera, as part of our assessment. When we look at the prevalence of obesity, the CDC reports that the prevalence of obesity among adults in the U.S. was 40.3% between 2021 and 2023. In 2023, 20 states, Guam and Puerto Rico, had an obesity prevalence between 35% and less than 40%. And when we're looking at the projected rates of obesity by 2030, we can see that the rates of obesity in the United States will exceed 45%. And when we look at worldwide obesity in 2022, 1 in 8 people in the world were living with obesity. And worldwide, adult obesity has more than doubled since 1990, and adolescent obesity has quadrupled. When we look at the high costs of obesity, currently 17% of all healthcare dollars is spent for the treatment of obesity and its complications. And estimates range from $174 billion to $210 billion per year. And there's undetermined costs related to hospital worker injury. And we know that severe obesity or metabolic obesity is a metabolic disease. As BMI increases, the adipose tissue becomes very metabolically active and secretes many hormones. These hormones or cytokines are very pro-inflammatory and influence insulin resistance, hyperlipidemia, inflammation, thrombosis, and hypertension. And the mucosa of the stomach of persons with obesity, there's a higher production of the hormone called ghrelin, which increases appetite. And also the neuropeptides and neurotransmitters in the brain, primarily in the hypothalamus, and other hormones affect satiety, appetite, and weight regulation. Interestingly enough, leptin, which is a hormone that is primarily secreted by the adipose tissue and decreases hunger, is found in higher levels for patients with obesity, but is believed that they are leptin resistant. When we look at some of the pre-hospital challenges, we have to make sure that we have appropriately sized gurneys. We sometimes need extra personnel to move the gurneys and other equipment. We have to think about airway management. There's often less room in the ambulance and can be delays in transportation if they need a specialized ambulance to transport the patient. And some of the other pre-hospital challenges is that some patients are unable to fit through the doors, and in the homes where patients are being picked up, they may need to remove the walls or the doors or other areas to transport the patient. There's the risk of injury to medical providers at the scene, and it requires sturdy equipment that can either fit the body habitus or the weight capacity. And the standard backboard is that the patient may not or fit or support the patient's weight. And for general care considerations, with the causes of admission, the consequences of comorbidities related to obesity can certainly exacerbate those comorbidities and increase the complications. And physical assessments and safe patient mobilization, pharmacology, and many other aspects of care are affected. So understanding the risk associated for patients with obesity may prevent complications and be life-saving. And when we look at trauma and obesity, is that the adipose tissue can cause challenges when making a physical assessment. We know that the literature states that individuals are less likely to wear a seat belt because of discomfort. There's also a higher incidence of chest injuries. There's a greater risk of pelvic fractures, and there's a higher mortality with blunt trauma. And vehicles are designed to provide safety to passengers of an average weight and height. And so the seat belts may not be long enough. And interestingly is that obstructive sleep apnea is very common among individuals that are affected by obesity, and is estimated in some of the studies that it's as high as 30% of all commercial drivers are affected by obstructive sleep apnea, and this can increase the risk of a motor vehicle accident. And with heart disease, we know that it can increase the overall morbidity and mortality related to coronary artery disease, atherosclerosis, hyperlipidemia, hypertension, congestive heart failure, sudden cardiac death, and peripheral vascular disease. When we look at hypertension, 75% of hypertension can be attributed to increased weight unless there is a genetic risk. And, it's not only just the lipid deposits in the vessels that is problematic. Obesity is characterized by chronic inflammation with these cytokines, and also it's the inflammation of the vessels. They have also increased triglycerides, decreased HDL, increase in catecholamines, increase in renin, and increase in aldosterone, which can lead in increased afterload. And other cardiovascular system changes is that they have increased blood volume, and this can lead to increased preload that can result in left ventricular hypertrophy. They can also have a greater right ventricular mass and a modestly lower right ventricular ejection fraction. We know that atrial fibrillation and myocardial infarctions are much more common. And we know that diastolic dysfunction and ventricular failure can also lead to death. Other things that we need to think about is making sure that we have the appropriately sized blood pressure cuff. We might want to think about continuous ECG monitoring, also perhaps consider invasive arterial blood pressure monitoring. And we need to be cautious with beta blockers because they need to be used cautiously due to the impaired ventricular contractibility as a result of decreased beta adrenergic receptors. And other EKG considerations is with the increased fat deposits around the heart, this can lead to degeneration of the conduction system, which can lead to lethal heart rhythms. We also can have difficult landmarks for placing the leads, which can lead to inconsistent or decreased voltage. We might also observe prolonged QT intervals and also observe nonspecific flat inverted T waves in the inferior leads. And when we look at pulmonary considerations, we know that there's certainly a decrease in lung volumes, which can lead to the increased work of breathing. There's higher airway resistance due to the additional weight on the chest, a higher chest wall. We also have decreased respiratory system compliance. They may have flattened diaphragms and altered lung volumes due to that additional weight. And of course, this can all lead to the increased energy cost of breathing. When we look at obesity hypoventilation syndrome, also known as Pickwickian syndrome, these individuals have left and right-sided heart failure, or at least it's very common, which can lead to hypoxemia and hypercarbia. They have increased soft tissue of the hypopharynx, which can cause partial obstruction of the airway, and this can lead to chronic respiratory acidosis. And obstructive sleep apnea is very prevalent. And we know that if an individual is 100 pounds overweight, that 90% of men will have obstructive sleep apnea, and 93% of women will have obstructive sleep apnea. The studies suggest that the life expectancy can be 20 years shorter. And obviously, what happens is that they don't get into the stage 4 quality sleep. They have a lot of daytime sleepiness, and this certainly increases the risk for obstructive sleep apnea. At Sharp, we took this threat so seriously that we began screening anybody whose body mass index is 30 and greater for obstructive sleep apnea and recommending a sleep study. What's concerning is that 80 to 90% of individuals don't know that they have obstructive sleep apnea. And one of the local hospitals here, they made sure that they did some education with their nursing staff about snoring, and that it's probably related to obstructive sleep apnea, and they significantly decreased their rapid response calls as well as their code blues. So it's really important to educate the staff about the risk of obstructive sleep apnea. And also very important to encourage patients to use their CPAP during hospitalization, because especially when we're often using narcotics, and you have narcotics which are very lipophilic and then have the combination with obstructive sleep apnea, it's really important to keep that airway open and encourage patients to use their CPAP. And we also want to anticipate if there's going to be a difficult airway. And one of the ways that we can do that is by the Malapati score and have the patient look in to see if they have an open airway. And we also know that patients with obesity saturate very rapidly due to the decreased respiratory reserve and lung capacity. And we have to assess reasons that their O2 sat or oxygen saturation levels are less than 92%. Because when individuals with obesity desaturate, they desaturate very rapidly, and immediate intervention is critical. And also, if necessary, we can put them in the reverse Trendelenburg position because it can drop the pannus of the abdominal fold from the diaphragm. And also, when we're looking at intubation, we often will put patients in the rapid airway management position where we align the top of the ear with a sternal notch, and we ramp up the occipital area using pillows or towel. We actually have a special pillow that is like that trapezoid shape that we put underneath the back of the neck or at the back of the head when we're intubating our patients that, with obesity. And we also noticed that it may be difficult to get a good seal with a bag mask device, and that the neck anatomy can be distorted due to excess tissue. And pre-oxygenation can be really critical because, as I mentioned, they can desaturate more quickly. We may want to keep them in an upright or semi-recumbent position as long as possible. And because they have reduced pulmonary compliance, we may need to think about higher ventilatory pressures. Also, if they have no C-spine injury, we need to keep the head elevated during pre-oxygenation when possible. And when we look at mechanical ventilation, the tidal volume has to be adjusted to the ideal body weight, not just the measure weight. These individuals also have a greater potential for atelectasis, and PEEP and other ventilatory strategies may need to be considered. And of course, the supine position is harmful because of the intra-abdominal pressure, and this can lead to reduced lung volume and hypoxia. And we know that there is a higher risk for respiratory failure acute respiratory distress or ARDS, and pneumonia. And we need to think about interventions for preventions, such as therapy with continuous pulse oximetry, end-tidal CO2 monitoring, prophylactic use of non-invasive ventilation post-extubation, longer endotracheal tubes and tracheostomy tubes. In fact, we worked with Johns Hopkins at our hospital to look at getting the longer endotracheal tubes in and what they were using in the LifeLight program. And so we certainly made sure that we have difficult airway kits in pulmonary services and in ED, in the OR, et cetera, that has this necessary equipment. We also need to think about oral intubation, and we need to definitely make sure that we're using the incentive spirometry and coughing and deep breathing more frequently. In fact, we have our patients make sure they take the incentive spirometer home as well as a coughing and deep breathing device and make sure that they use it for a couple more days when they're discharged from the hospital from bariatric surgery. We also want to consider using glide scopes for successful intubation. And the meta-analysis for prolonged mechanical ventilation is conflicting. And when we look at obesity and links to other diseases, when we look at the lifetime risk for cancer, that for someone who is of a healthy or normal weight, the lifetime risk is around 3%. But when someone is affected by obesity, that risk jumps up to 52%. There's at least 19 cancers that are related to obesity. What's interesting is that even with the dosing of the chemotherapy, we don't really have an exact knowledge of the pharmacokinetics of even the chemotherapy medications. When we look at the renal impact, some drugs may impact the renal system in high BMI patients due to high glomerular filtration rates. And so also we note that they have increased intra-abdominal pressure, and this can lead to hypertension and insult to the kidney. If someone's BMI is more than 35, there's nearly twice the risk for kidney failure. If someone's BMI is 40 or above, there's 7 times the risk of kidney failure. Those kidneys have to work very hard to perfuse that additional body weight. And with weight and drugs, we have to be particularly concerned about drugs that are very lipophilic, and because they're highly soluble in fat, and with extended time duration, such as greater than 12 to 24 hours, they are actually absorbed into the fat tissue. And the medications that we need to be concerned about are morphine, Dilaudid, Tegretol, Propofol, fentanyl, and Versed. And we know that individuals also have greater gastric volume, which can significantly increase the risk for aspiration. So you really need to think about that when individuals require tube feedings. And also they have a much higher risk of gastric reflux or GERD. There is a higher incidence of hiatal hernia, but also there is that increased intra-abdominal pressure, which can push the gastric juices or fluid up into the esophagus. And because of that reflux into the esophagus, this can lead to bronchitis, asthma, and Barrett's esophagus. And also to support the patient, we sometimes will use an abdominal binder, and the abdominal binder can help decrease the pressure from the pannus onto the abdominal incisions if they have surgery or if they're in a trauma situation. It can provide some comfort and support, and it also can help with the pressure or support of the back, and because of the weight of the pannus. And with non-alcoholic fatty liver disease, if someone's BMI is 40 and greater, the prevalence of non-alcoholic fatty liver disease is more than 95%. And for the NASH, or the non-alcoholic steatohepatitis, it may be as high as 25%. And what's interesting is that for our patients that are having bariatric surgery, we actually put them on a 2-week liver shrinking diet, which is like 3 protein shakes and a healthy low-fat, low carb meal 2 weeks before their surgery. And because the surgeons have to lift the liver up to perform bariatric surgery, and we don't want that liver to crack or bleed. So again, it's a very prevalent condition, and the sustained liver injury leads to progressive fibrosis and cirrhosis in 10 to 25% of affected individuals. And also trauma patients may be at increased risk with the larger livers. And we know that diabetes is clearly related to individuals that are affected by obesity. And it's one of the leading causes of death in the United States and one of the most costliest diseases in the United States. Over $245 billion is spent annually. And there are some estimates that predict that diabetes may double by 2030 due to this epidemic. And the stress of critical illness can deplete protein rather than glucose stores. And we know that hyperinsulinemia can lead to sodium retention as well. And we know that individuals have a much greater risk for blood clots. And so we know that, as I mentioned earlier, that obesity is characterized by chronic inflammation, decreased immunity, hypercoagulability. And this is due to the decreased antithrombin, increased tumor necrosis factor alpha and interleukin 6. They have impaired neutrophil function and increased blood volume. In fact, we, in our program, we have them get up out of bed upon 1 hour upon arrival to the nursing unit, and we have them walking every 30 minutes for a minute or two while they're awake for the next 3 weeks after their surgery, bariatric surgery, because of this significant increase of blood clots. And we make sure that they keep their sequential compression devices on them at all times, and we make sure that they have anticoagulation medications, especially critical for patients that are post-surgical or trauma or immobilized. And for venous access is that the landmark vessels may not be easily visualized or palpated and may require multiple attempts and delays in access. They may have higher complication rates secondary to multiple sticks or wound infections, phlebitis, and thrombosis. And the standard 1.5 inch needles may not be long enough for injections. And for emergent fluid resuscitation, you may need to consider intraosseous infusions. And we know that there's significant skin considerations or integumentary considerations. There's impaired wound healing due to the decrease in vascularity of adipose tissue, which can lead to bacteria and fungal overgrowth in skin folds, can lead to skin irritation, pain, and skin breakdown. And surgical site infections are more common. Also, with the weight of the abdomen on a lot of those vessels and the lower legs, is that they can be prone to lymphedema. There's also an increased risk of CAUTI because the pressure of the abdomen and the legs onto the catheter, and plus it's just harder to do catheter care, and so it can increase the risk for CAUTI. And we know that they can have atypical skin pressure ulceration, so it's important to move all the tubes and catheters every 2 hours to prevent that from happening. And so it's important to use some of the medical devices to prevent pressure injury, such as the longer straps or wider straps for Foley catheters and for trach holders. And we also need to think about our workers who are caring for these patients and make sure that we have appropriately sized equipment and supplies. And in our organization, we use weight capacity stickers just to make it easy for our staff to identify which equipment is appropriate. And we also have a policy for ordering bariatric equipment. And we also want to make sure that our staff are educated on our safe patient mobilization policy and guidelines. And we actually do use bariatric models in many of our staff education. And when you look at this picture, does this make you feel sad? What do you think? So Yale Rudd has done a lot of studies regarding weight bias in healthcare. And what they had indicated is in a recent study among student dietitians, only 2% had a neutral or positive attitude towards individuals with obesity. Many of them are not understanding that it is a metabolic disease. They realize that what happens is that they are assuming that if they give them appropriate diet and exercise that they would lose the weight. But the body's very compensatory, and as individuals, lose about 10% of their body, the body sort of fights back and releases a lot more of those hormones. And so many of those individuals over time, even though they've been able to successfully lose weight with diet and exercise, especially for those with the more severe forms of obesity, that those individuals have a higher incidence of weight regain. In one study among nurses, 31% would prefer not to care for patients with obesity, and that they agree that patients with obesity repulse them, and even 12% would prefer not to touch patients with obesity. And a lot of it is that it takes a lot more time to bathe them, mobilize them, and to care for them. In several anonymous self-report surveys, physicians viewed patients with obesity as non-compliant, lazy, lacking self-control, unsuccessful, unintelligent, and dishonest. And I think that the lacking self-control is that they are concerned that they are not following the recommendations for their diet or their exercise, and that they're not being honest about their intake. So that's the reason I think they come up with the word dishonest. But honestly, we know that individuals work very hard to lose the weight, as I mentioned, because of all the hormonal influences. It makes it very challenging for them to lose the weight for those that have the more severe forms of obesity. And in a large study, over 2,400 women who were overweight or affected obesity reported that 52% of physicians had been stigmatized by physicians more than once, and that overall physicians spent less time with them. They assigned more negative symptoms and had the reluctance to perform certain screenings, such as Pap smears, etc. So what happens is that our patients delay seeking preventive health care. There's discrimination in every social aspect, which leads to depression, low self-esteem, and more. There's also the fear of worker injury and the extra time to mobilize patient, which can lead to resentment in patients and less mobilization by providers. And so patients may wait to seek healthcare until they become critically ill. So we have to remember that how we think and how we feel is reflected in our eyes. And it's important that we show compassion, because compassion can truly make a change. So with that, we'll have Christy take over the presentation. And again, I thank Dale Medical and Sachs Communications for supporting this webinar.
Thank you, Cheryl, for a most informative session. I'd like to inform our viewers how to obtain their CEs for this session. The activity has been approved for 1 contact hour. You can obtain those continuing education credits by logging on to www.saxtesting.com/P. You will need to register on the test site, complete the evaluation form, and upon successful admission, you will be able to print your certificate of completion. Again, thank you to Dale Medical for supporting this program today through an education grant. There will be an archive on-demand version available on www.perspectivesinnursing.org. The on-demand version will be accredited for CEs. So I'd like to jump to the Q&A portion. And Cheryl, one question, what about the incidence of pressure ulcers with obese patients caused by medical devices?
So it varies. You know, what we find is that that organizations that do extensive education with their staff is that the incidence is lower. I don't know the overall, like for example, the national incidence at the top of my head, but we know that when our staff are educated about moving the tubes and catheters and also checking for pressure ulcers at least every 2 hours, that the incidence significantly decreases.
Thank you. Our next question is about abdominal binders and other commercially available devices for obese patients.
And so it is available through different manufacturers. And, you know, I know that Dale Medical has some of those devices. And they're really important because it really makes a difference as far as not putting all the pressure on either the arms or the legs. And also it helps provide some comfort for the patient. So you want to make sure that it's appropriately sized, but you also have to make sure that if you're using an abdominal binder, that you're definitely assessing either the wounds or incisions frequently to make sure that it's not irritating to those incisions, and just providing really good skin care.
Thank you. Our next question is, do you use a vascular access specialist or IV team to place IVs in this patient population?
We do as needed. So the nursing staff can consult with the vascular access team to have them come and see a patient as needed.
And then regarding obesity hypoventilation syndrome, do you have any guidance regarding cognitive alteration or chronic hypercapnia?
Yes, it can lead to both.
Look for other questions, some positive comments in here. Do you see many complications related to medical tourism?
So we do see that occasionally, and it is a concern. We here in San Diego, we're across the border, and so we do see individuals, because sometimes it may be of a decreased cost, so we do get concerned about that. But one of the things that we try to do is make sure that we provide really good education about going to an accredited program to decrease the risk for complications.
Thank you. Our next question. Could you go into a little bit about trach size, trach tube size, and style that might be beneficial for these patients?
So it really has to be individualized depending on their neck circumference. So you really just have to make an individual assessment, and then just look at the manufacturers that have the longer trach ties. We actually had to get longer trach ties here at Sharp, but it really has to be individualized with neck circumference.
And should a patient who is obese and a DNR full support and a BiPAP machine is required, would you recommend using AVAPs instead of BiPAP where a tidal volume may be targeted?
I don't have that expertise to make that assessment, to be honest with you. I would have to defer to pulmonary services for that.
And let me continue to look. This question with a situation with it, I totally understand that patients feel like they're not heard when they are overweight and obese. How do we make doctors more aware of diseases that are not very common?
So one of the things that we encourage is that we have done a lot of education here at Sharp, and but I think it's also important to have webinars at the hospital for experts that have experience, and invite them to participate in some of the education.
Thank you, Cheryl. Next question. This participant, their facility tends to focus on heart failure with preserved ejection fraction with rapid aggressive diuresis. This often leads to hypochloremic metabolic acidosis and worsening compensatory hypercapnia. Does your system or facility have a process to recognize and manage this?
Yes, we do. We do have a lot of clinical nurse specialists and experts in this area. For example, all the surgical ICUs and medical ICUs have annual training on caring for bariatric surgery patients. And so we do have a lot of experts in this at our organization to help evaluate that.
Are there any supportive garment brands that you can recommend for patients who have had bariatric surgery and have excessive loose skin?
So what we usually do tell them to do is we recommend that they actually do see a dermatologist, and usually the consult appointment with them is free so that they can make an evaluation of the appropriate garments.
And this is more of an opinion question here, but what do you think about Ozempic in these obese population, in these obese patients?
So
Do you
there's
think
when
it's helpful?
Certainly, I think that what we look at in the surgical aspect is we are glad, just like when we look at cardiovascular disease, prevention is key. But if someone needs a more aggressive treatment with their cardiovascular disease, we may add a pharmacological agent. And likewise, in the surgical world, we may want to consider pharmacology to get weight off before surgery and after surgery. And so they're getting really they're becoming very good medications. And so there's, right now they are injectables, but there's also, it looks like Eli Lilly is in the middle of developing an oral anti-obesity medication, but we continue to make great strides in the pharmacological approach to treating this disease.
Thank you. Next question. Does your organization provide community outreach education geared toward bariatric patients and their families to make them feel more comfortable?
Yes, we do. We've had different conferences as well, and but we also have free webinars, and so we do try to reach out. And our program will attend different community programs such as the Women's Conference and other conferences to help educate our individuals about resources that are available to them.
Thank you. Let's see. Next question. How do you and your team get obese patients ambulating?
A lot of it is the preoperative education. So during the preoperative class, I let them know that the expectation is that they should get up and walk within 1 hour, but they should have a nursing staff member with them for the first walk because of the medications that they received. And I talked to them about why ambulation is so important, that, it decreases the risk for blood clots, it gets their bowels moving, it'll help them with their abdominal pain because it moves their core, it'll help burp out all the air that they swallow during their surgery. And I think that because of all the education, and also not only of the patient education that we provide in the pre-op class, but also the staff education, because the staff have all been education. In fact, interestingly enough, is that I actually check every patient record to make sure that the patient got the patient up and ambulating within 1 hour upon arrival to the nursing unit. It is extremely rare. We tell them, have them sit and dangle for 5 minutes if you need to, and just move them slowly, do an assessment to make sure that they're not at a fall risk. But 99.9% of our patients are ambulated within 1 hour. And I think the preoperative education and staff education has made a really big difference in that area.
And then what happens with any tubes when they're ambulating?
So our patients, as far as for tubes,
just I think obese patients in general, when they're up and ambulating, what can we do to help promote ambulation when they might have tubes and additional things that need to be managed?
Sure. So, usually it may take a couple of individuals to ambulate the patient, if they have Foley catheters and IVs and so, et cetera. So sometimes it requires a team effort rather than just one nurse.
And what about internally? There was a question we had about, maybe community education, but what about internal education for compassion and caring for this bariatric population in the hospital? Is there anything our facility does for that?
Yes. So every healthcare provider receives education upon hire on weight sensitivity, and all the nursing staff that have direct care of these patients, the bariatric surgery patients, have to take an annual module. We have system modules on weight sensitivity, and so we are a large healthcare system. We're the largest healthcare system in San Diego, but all of the new hires who are healthcare providers do receive education on weight sensitivity.
Thank you, Cheryl. And another question about pressure ulcers, more targeted for those CPAP or BiPAP masks. Is the issue more with headgear or the mask itself? Any recommendations on how to address that concern?
So it can be actually both, because, depending on the face, the shape of the face, and getting a good seal, or even in the mask. And sometimes you just have to be creative about seeing what works individually with that patient and trying a couple different things.
And I'm looking through the questions. I'm not seeing any more questions at this time. Are there any additional questions that anyone would like to place into the chat for Cheryl?
I just want to
Well,
say
thank you everyone for all of your, I'm sorry, were you going to say, Cheryl?
I just want to say these are all really great questions, and I really appreciate them very much.
Yes, I really do like the interaction from the audience today. Thank you for your questions and comments in the chat. So thank you for attending this webinar. Immediately upon the conclusion of the webinar, you'll be presented with an online survey. Please keep your web browser open. We appreciate your feedback. The CE Certificate of Completion will be available in 1 hour following the conclusion of the webinar. You will receive an email with instructions and this link to obtain your CE credits, www.saxtesting.com/P.
And with that, we'd like to thank everyone for attending today's session, and we hope you have a great rest of your day. Thank you.